Assalamu alaikum. I am Dr. Samar Muhammad. We will talk about red blood cells disorders. At the end of this lecture, you should be able to define and classify anemia, evaluating the patient with anemia, define clinical and laboratory findings that are commonly associated with different types of anemia. Composition of blood. Blood is composed of plasma and cells. There are three types of blood cells: erythrocytes, leukocytes, and platelets. These cells compose approximately 45 to 50% of the volume of the blood. Reference ranges vary depending on sex, age, geographical location, and to lesser extent, the race. This picture shows three types of peripheral blood cells. Hematopoiesis. Hematopoiesis is the formation of blood cellular components. Normally, bone marrow responsible for formation of new blood cells. In a healthy adult person, approximately 10 multiplied by 11 to 10 multiplied by 12 new blood cells are produced daily in order to maintain steady state levels in peripheral circulation. Hematopoiesis occur in different sites according to different stages of life. During infancy, all bone marrow is hematopoietic, the red marrow or functioning marrow. During childhood, there is progressive fatty replacement of the marrow of long bones by yellow marrow or non-functioning marrow, so that by age of 20 years, the marrow cavities of peripheral bones have stopped producing blood cells and becomes yellow marrow. The red or hematopoietic marrow becomes confined only to axial or central skeleton, as ribs, vertebrae, sacrum, in addition to proximal ends of femur and humeri. This picture shows process of hematopoiesis. Cells in bone marrow derived from hematopoietic pluripotent stem cells to give rise to blood lineage that ends by formation of three types of blood cells: erythrocytes, platelets, and leukocytes. This picture shows process of hematopoiesis. Cells in bone marrow derived from hematopoietic pluripotent stem cells to give rise to blood lineage that ends by formation of three types of blood cells: erythrocytes, platelets, and leukocytes. This picture shows process of hematopoiesis, in which myeloid stem cells will proliferate and differentiate to give rise to erythroid precursors that passes by different stages of maturation to give rise to mature RBCs. This picture shows process of hematopoiesis, in which myeloid stem cells will proliferate and differentiate to give rise to erythroid precursors that passes by different stages of maturation to give rise to mature RBCs. Erythroid maturation or erythropoiesis. Erythropoiesis is process of production of mature RBCs in adult bone marrow. As we mentioned before, proliferation and differentiation of hematopoietic pluripotent stem cells gives rise to erythroid precursors. Maturation of erythroid precursors is identified by different morphological and functional changes. As we see, during maturation, cell size will be decreased, cytoplasmic ratio will be increased, nuclear size decreases, and later on disappears. Cytoplasmic staining changes from blue to pink shred. Chromatin pattern matures and disappears with nucleus later on. These stages of maturation takes from 5 to 7 days in bone marrow, then enter circulation to end by formation of mature RBCs. Erythroid maturation or erythropoiesis. Erythropoiesis is process of production of mature RBCs in adult bone marrow. We mentioned before, proliferation and differentiation of pluripotent stem cells result in production of erythroid precursors. Maturation of these erythroid precursors is identified by different morphological and functional changes. As we see, cell size will be decreased, cytoplasmic ratio increased, nuclear size decrease and later on disappears. Cytoplasmic staining changes from blue to pink shred. Chromatin pattern matures and disappears with nucleus later on. Stages of maturation takes from 5 to 7 days in bone marrow, then enter circulation as mature RBCs. There are many factors affecting or regulating erythropoiesis, as erythropoietin production, iron availability, which is essential for synthesis of heme or hemoglobin, proliferative capacity of the bone marrow, effective maturation of red blood cell precursors. The key components of erythropoiesis. Erythropoietin is specific erythroid growth factor synthesized mainly in the kidney and stimulate erythropoiesis by acting on bone marrow stem cells. The most important stimulus for its release is tissue hypoxia. Hypoxia of renal tissue results in switch on erythropoiesis synthesis and production of it by peritubular cells. Erythropoietin stimulates stem cells within the bone marrow, which differentiate into erythroid precursors. Erythropoietin continues to stimulate primitive erythroid cells in the bone marrow and induce maturation. As with much human physiology, this system works via feedback mechanism. Red blood cells. Normal mature RBCs are round biconcave discs, pink in color with central pallor about 1/3 the size of the RBCs. Its size about 6 to 8 micrometer. RBCs can't define, grow, or form proteins. Normal cells with normal size and content called normocytic normochromic RBCs. Normal RBCs count. Normal RBCs count differ from men to women. In men, it ranges from 4.5 to 5.5 million per cubic millimeter. In women, it ranges from 3.8 to 4.8 million per cubic millimeter. This varies with sex, age, and geographical location. Higher concentrations are found in males and newborns, and at high altitudes. Decrease below the reference range result in anemia. Increased erythrocyte concentration results in erythrocytosis. Hemoglobin is intracellular protein in erythrocyte. Hemoglobin differs from men to women. In men, it ranges from 13 to 17 gram per deciliter. In women, it ranges from 12 to 15 gram per deciliter. Normal hematological values for adults. As we mentioned before, normal RBCs count and normal hemoglobin are differ from male and female. There is another parameter called hematocrit or packed cell volume. Packed cell volume is defined as percentage of packed RBCs volume in relation to the whole blood volume. It's used in calculation of blood indices. What are the RBCs indices? These indices are values that can describe size and content of RBCs, and through it, anemia can be classified morphologically. RBCs indices are MCV, MCH, and MCHC. MCV means mean corpuscular volume, which defined as average volume of one RBCs, and ranges from 80 to 100 femtoliter. MCH means mean corpuscular hemoglobin and defined as average hemoglobin content of one RBCs. It ranges from 27 to 32 picogram. MCHC, which means mean corpuscular hemoglobin concentration and defined as average hemoglobin concentration in one RBCs, and ranges from 31.5 to 34 0.5 gram per liter. There is another parameter called reticulocytic count. Reticulocyte is immature RBCs. It released from bone marrow and contains remnant of ribosomal RNA. It spends 1 to 2 days before maturation in the spleen. Reticulocytic count is totally accurate reflection or index of erythropoietic activity. By another way, it reflects bone marrow activity. Normally, it ranges from 0.5 to 2.5%. Anemia. Anemia can be defined as state of insufficient RBCs mass leading to inadequate delivery of oxygen to tissues, thereby causing tissue hypoxia. Classification of anemia. It can be based on morphology, physiology, or etiology. According to morphology, based on size and color of RBCs, anemia can be classified into microcytic hypochromic, normocytic normochromic, and macrocytic. Microcytic hypochromic anemia caused by iron deficiency, thalassemia, sideroblastic, and 1/3 of cases of anemia of chronic disease. Normocytic normochromic anemia is caused by acute post-hemorrhagic, hemolytic, aplastic, anemia with malignant infiltration of bone marrow, and endocrinal disorders. Macrocytic anemia is caused by folate and cobalamin deficiency, alcoholism, hypothyroidism, anemia with malignancy. According to physiology or etiology, anemia can be caused by decreased RBC survival, as in cases of blood loss, either acute or chronic, or may be due to increased destruction, as in cases of hemolytic anemia, that will be discussed later. Anemia also can be result from marrow production defect or hypoproliferative defect, which may be due to aplastic, sideroblastic, and bone marrow infiltration. And finally, anemia can be caused by nutritional deficiencies, as in cases of iron deficiency. Types of anemia. According RBC's indices, anemia can be classified morphologically into microcytic hypochromic anemia, normocytic normochromic anemia, macrocytic anemia. In microcytic hypochromic anemia, all indices are decreased. In normocytic normochromic anemia, the indices are normal. In macrocytic anemia, there is increase in MCV and increase in MCH and normal MCHC. Microcytic hypochromic anemia. It can be caused by iron deficiency anemia, thalassemia. 1/3 cases of anemia of chronic disease can cause microcytic hypochromic anemia. Also can be caused by sideroblastic anemia, and finally lead poisoning. Hemoglobin is conjugated protein composed of 4 globin chain and 4 heme groups. Globin is fraction of amino acid used in protein synthesis. Heme is iron containing protoporphyrin attached to each polypeptide chain and combined to 4 oxygen molecules. Microcytic hypochromic anemia results from defective hemoglobin synthesis, which may be either due to defect in globin chain synthesis that ends by thalassemia, or may be due to defect in heme synthesis. Defect in heme synthesis may be due to reduction of iron availability that result in iron deficiency anemia or anemia of chronic disorders, or defect in heme synthesis may be result from reduction of protoporphyrin synthesis, which result in sideroblastic anemia and lead poisoning. Iron deficiency anemia. Iron deficiency is one of the most prevalent forms of malnutrition and so most common anemia worldwide. Iron deficiency anemia can be defined as decrease in amount of body iron resulting from a sustained increase in iron requirements over iron supply. Iron deficiency reduces the responsiveness of erythroid progenitors to erythropoietin. It is important and vital to understand how the body handles iron. Iron is a key constituent of hemoglobin. 60 to 70% of total body iron is stored here, and its availability is essential for erythropoiesis. Normal iron cycle. Iron absorbed from small intestine in the ferrous state, about 1 milligram per day, then attached to proteins called transferrin in plasma, where it is transported to bone marrow for hemoglobin synthesis. Dying RBCs recycled by macrophages in spleen, and iron is recycled into plasma for further use. In cases of iron deficiency anemia, there are more divisions of the RBCs during erythropoiesis than normal. As a result of this process, the RBCs become smaller in size and the hemoglobin content is reduced, resulting in microcytic hypochromic RBCs. Iron deficient state, there is bone marrow iron is reduced. There is another marker called soluble transferrin receptors, in which these receptors are present on the surface of the RBCs. These receptors are increased during cases of iron deficiency anemia. At the end, the serum iron profile during cases of iron deficiency anemia is: serum iron is reduced, serum total iron binding capacity is increased, serum ferritin is reduced, soluble transferrin receptors is increased. Causes and clinical presentation of iron deficiency. Iron deficiency may be result in increased iron loss or blood loss, increased iron requirements or hematopoiesis, decreased iron intake or absorption. The most common cause that can result in iron deficiency anemia is chronic blood loss, may be due to menstrual blood loss and blood loss related to pregnancy or labor, or bleeding from gastrointestinal tract as in cases of peptic ulcer, hiatus hernia, and esophageal varices. Other causes may result in increased iron loss or blood loss as blood donation or phlebotomy as a treatment for polycythemia vera. Increased iron requirements or hematopoiesis as in cases of gross pregnancy, lactation, and erythropoietin therapy. Decreased iron intake or absorption due to dietary insufficiency of bioavailability iron, acute or chronic inflammation, or cases of impaired absorption as in malabsorption syndrome or gastric surgery. Clinical presentation of iron deficiency anemia depends on severity of iron deficiency. The common signs and symptoms are pallor, palpitation, tinnitus, headache, irritability, weakness, glossitis, angular stomatitis, impaired immunity and resistant to infection, diminished exercise tolerance, and work performance. Sequential changes or stages of iron deficiency anemia. The first, negative iron balance or iron depletion, when demands for or loss of iron exceeds the body ability to absorb iron from diet and starts iron store depletion. The second, iron deficient erythropoiesis after the depletion of stores. Once transferrin saturation falls up to 50%, hemoglobin synthesis become impaired, and later on, frank iron deficiency anemia occur. During this stage, both iron store and serum iron depleted and hemoglobin hematocrit begins to fall, reflecting iron deficiency anemia. Transferrin saturation at this point is up to 15% with hypochromic and microcytic RBCs. Sideroblastic anemias. As we mentioned before, hemoglobin is composed of heme and globin. Globin is fraction part of amino acids that enter in protein synthesis. Heme is iron containing protoporphyrin. The defect in protoporphyrin will result in sideroblastic anemias. Sideroblastic anemias are rare heterogeneous group of refractory anemias caused by failure of synthesis of porphyrin ring, characterized by presence of ringed sideroblast in the bone marrow aspirate, dimorphic blood picture. As we see in this picture, there are two types of RBCs. One of them is microcytic hypochromic and the other is normocytic normochromic. Microcytic hypochromic RBCs are seen in hereditary cases of sideroblastic anemia. There are increased in serum iron concentration and markedly increase in iron store. And finally, there is ineffective erythropoiesis due to non-viable sideroblast. This table shows different serum iron profile values in different cases of microcytic hypochromic anemia. Serum iron profile are iron, ferritin, total iron binding capacity, and transferrin saturation. In cases of iron deficiency anemia, all are decreased except total iron binding capacity is increased. In case of anemia of chronic disorders, all are decreased except ferritin is increased. In cases of thalassemia, all are increased except total iron binding capacity is decreased. Differential diagnosis of microcytic hypochromic anemia. As we see in all cases, iron deficiency, anemia of chronic disease, thalassemia, sideroblastic anemia. In cases of lead poisoning, there is a history of lead exposure and serum iron profile are normal. How to approach to a case of microcytic hypochromic anemia. If microcytic anemia is suspected, first check serum ferritin. If it is low, suspect iron deficiency anemia. If serum ferritin is normal or elevated, check for inflammation, clinical and/or CRP. If inflammation is present, consider as anemia of chronic disease and check full iron status to ensure not iron deficient. If there is no evidence of inflammation, consider thalassemia. Normocytic normochromic anemia. It may be due to anemia of chronic disorders or may be due to decreased production, as in cases of aplastic anemia or pure red cell aplasia, or may be due to increased destruction or loss, as in cases of hemorrhage and hemolysis, or also may be due to hypersplenism. Anemia of chronic disorders. It is a common type of anemia that occurs in patients with infectious, inflammatory, or neoplastic diseases that persists more than 6 months. Pathogenesis, impaired reutilization of iron, activation of reticuloendothelial system with increased iron storage within it, and decreased release of iron from macrophages to circulating transferrin. Normally, there is hormone-like protein called hepcidin. Hepcidin synthesized by the liver and considered as principal regulator of iron metabolism, in which it is responsible for ferroportin internalization. In presence of any inflammatory stimulus, monocyte activation will occur, result in release of many of cytokines as interferon gamma, tumor necrosis factor alpha, interleukin 1 beta, and interleukin 6. These cytokines stimulate hepcidin release, result in inhibition of iron release from macrophage and inhibition of iron absorption from GIT. So, in cases of anemia of chronic disorders, there is no depletion of iron stores, but iron can't be used. Lab diagnosis in cases of anemia of chronic disorders. CBC or complete blood count show anemia, which is normocytic normochromic anemia or microcytic anemia in 1/3 of cases. Blood film show no abnormal cells. Reticulocytic counts are reduced. Iron profile. In cases of anemia of chronic disorders, serum iron profile all are decreased except the ferritin is increased. Hemoglobin electrophoresis is normal. Aplastic anemia. Aplastic anemia is one of the bone marrow failure syndromes, which are characterized by peripheral blood pancytopenia. Pathogenesis. Marrow aplasia is considered as a consequence of immunologically mediated destruction of hematopoietic cells or direct suppression of hematopoiesis by pathogens or drugs or chemicals. Causes of aplastic anemia. may be congenital or acquired. Congenital aplastic anemia, as in cases of Fanconi's anemia. Acquired aplastic anemia may be due to aplastic crisis of hemolytic anemia, infectious disorders such as cytomegalovirus or viral hepatitis, immunological disorders, or cytotoxic drugs. Lab diagnosis of aplastic anemia. Aplastic anemia show picture of pancytopenia in CBC, anemia, leukopenia, and thrombocytopenia. Peripheral blood film show no abnormal cells. Retics are reduced. Bone marrow examination. In cases of bone marrow aspirate, hypoplasia with loss of hematopoietic tissue and replacement by fat more than 75%. Trophine biopsy is essential as aplastic anemia is patchy form of disease. The main cells present are lymphocytes and plasma cells. Megakaryocytes in particular are severely reduced or absent. How to approach to a case of normocytic normochromic anemia? First, make reticulocytic count. If it is increased, suspect hemolysis or blood loss and search for the cause. If there is no increase in retics count, search for other cytopenias and abnormal leukocytes. If present, bone marrow evaluation for aplastic anemia, marrow infiltration, myelodysplastic syndrome. If there is no evidence of other cytopenias or abnormal leukocytes, evaluate clinical history. Check chronic illness. If present, suspect anemia of chronic disease. Check renal function. If there is a problem, suspect anemia of renal failure. If there is antecedent viral illness, drugs exposure, lymphoproliferative disorders, or mediastinal mass, bone marrow biopsy is recommended to evaluate red cell aplasia. Macrocytic anemia. Macrocytic anemia can be caused by false macrocytosis or true macrocytosis. False macrocytosis may be due to reticulocytosis or red cell agglutination. True macrocytosis may be due to megaloblastic causes and non-megaloblastic causes. Megaloblastic causes as vitamin B12 and folate deficiency. Non-megaloblastic causes as alcohol, liver disease, post-splenectomy, and hypothyroidism. Megaloblastic anemia is defined as macrocytic anemia characterized by multi-system affection due to DNA reversible defect resulted from vitamin B12 and folate deficiency. DNA defect result in intramedullary hemolysis, and this defect is reversible as it can be corrected by therapeutic use of vitamin B12 and folate. Pernicious anemia. Pernicious anemia is autoimmune megaloblastic anemia in which body's own immune system mistakenly damages its own tissue. Lab diagnosis of macrocytic anemia. CBC show increased in MCV. There is cytopenia. White BCs and platelet may be or may be not reduced. Peripheral blood film show hypersegmented neutrophil, as we see in the picture. Neutrophil with 6 loops, or also hypersegmented neutrophil can be more than 5% of neutrophils with at least 5 loops. The picture of blood film show also ovalomacrocyte RBCs which characterized in cases of megaloblastic anemia. The evidence of hypersegmented neutrophil is early evidence, even appear before anemia. Retics in cases of macrocytic anemia are reduced. Bone marrow examination show hypercellular bone marrow and hyperplasia of all series of the marrow. Large erythroblast, failure of maturation, open fine chromatin, but normal hemoglobinization. There is giant and abnormally shaped metamyelocytes. LDH is increased due to marrow cell breakdown. How to approach to a case of macrocytic anemia? First, exclude non-megaloblastic causes. Blood film is recommended for assess the morphology and exclusion false macrocytosis. Trials of therapeutic vitamin B12 and folate is recommended. If there is improvement, suspect megaloblastic anemia. If there is no improvement, bone marrow examination is recommended. Evaluating the patient with anemia. Patient history, dietary habits, medication, exposure to chemicals and toxins, any history of medical problems that could be cause anemia, as sickle cell disease, thalassemia, renal disease, hereditary spherocytosis. Symptoms of anemia and their duration. Symptoms of anemia depends on rate of decline of hemoglobin. Maybe fatigue, headache, muscle weakness, vertigo, syncope, dyspnea, palpitations, previous record of abnormal blood examination, and family history of abnormal blood examination. Signs of anemia obtained by physical examination. Maybe their skin pallor, pale conjunctiva, hypotension, jaundice, chylomicrosis, smooth tongue, splenomegaly, hepatomegaly, bone marrow deformities in congenital cases, and finally neurological dysfunction as in cases of megaloblastic anemia. Investigation into anemia. Anemia should be differentiated from each others, macrocytic, microcytic, or normocytic. In cases of microcytic hypochromic anemia, serum iron and blood film is recommended. In cases of normocytic normochromic anemia, reticulocytic count and blood film is recommended. In cases of macrocytic anemia, blood film and reticulocytic count is recommended. Hemolytic anemia. Red blood cell turnover. Mature RBC's lifespan is 120 days in circulation under normal condition. Normal RBC's destruction. Aged RBCs phagocytosed by reticuloendothelial system, as liver and spleen. Hemoglobin is released from RBCs destroyed to release heme and globin. Globin is the fractional part of amino acids that used in protein synthesis. Heme is iron containing protoporphyrin, digested by heme oxygenase to release iron and protoporphyrin. Iron will be stored as ferritin in macrophage, then taken by transferrin for use in resynthesis of hemoglobin. Protoporphyrin break down into carbon monoxide, which expired in air, and bilifirdin, which is reduced to form unconjugated bilirubin. Unconjugated bilirubin will be taken by the liver to be conjugated bilirubin. Then, in small and large intestine, deconjugation and reduction occurs to result in formation of stercobilinogen and urobilinogen. Urobilinogen is secreted in urine, and a small part of it is reabsorbed by the kidney. Stercobilinogen mainly excreted in the stool and responsible for color of stool. Normal hemoglobin in adult blood. As we mentioned before, hemoglobin is conjugated protein composed of 4 globin chain and 4 heme group. The 4 globin chain is R, 2 alpha and 2 beta chain. 4 heme groups are iron containing protoporphyrin attached to each polypeptide chain and combined to 4 oxygen molecules. Normal human hemoglobin differ in each stage of life, adapted to particular oxygen requirements, and according to type of polypeptide globin chain, there are different types of hemoglobin. In adults, hemoglobin is formed of hemoglobin A, hemoglobin A2, and hemoglobin F. The mean hemoglobin in adult is hemoglobin A. Hemolytic anemia. Hemolytic anemia is a group of disorders leading to anemia that result from increase the rate of RBC's destruction, shortening of the RBC's lifespan less than 120 days. The patient may not always be anemic, depending on the degree of marrow compensation and the rate of RBC's destruction. Anemia is the result of premature destruction of RBCs exceeding the erythropoietic capacity of the bone marrow. In cases of hemolytic anemia, destruction of RBCs may be extravascular or intravascular. In extravascular hemolysis, RBCs engulfed by phagocytic cells and degraded into heme and globin. Globin enter in protein synthesis, and heme is iron-containing protoporphyrin. Iron will be binds to transferrin and used in hemoglobin synthesis. Protoporphyrin will be converted into unconjugated bilirubin, which is uptaken by the liver to converted into conjugated bilirubin. Then, in small and large intestine, bilirubin will be converted into stercobilinogen and urobilinogen. In cases of intravascular hemolysis, RBC lysis occur inside blood vessels. There is free hemoglobin escape into plasma and binds to haptoglobin. Hemoglobin haptoglobin complex cleared by macrophage in the liver, where hemoglobin is fractionated into protoporphyrin and unconjugated bilirubin. Free hemoglobin exceeding capacity of haptoglobin. There is excess dimers, which filtered by the kidney, causing hemoglobinuria. Clinical features of hemolytic anemia. Onset may be acute or insidious. Asymptomatic or compensated hemolytic anemia. Bone marrow can increase production up to 8 times than normal. Symptoms and signs of anemia as pallor, headache, weakness, and lethargy, jaundice and splenomegaly. Most congenital hemolytic anemia except sickle may be result in increased risk of pigmented gallstones and chronic leg ulcers, skeletal abnormalities as bone marrow expansion and bone changes. Stool is darker while no change in urine color unless hemoglobinuria, or may be complicated by crisis as acute hemolytic crisis, megaloblastic crisis, aplastic crisis, or vaso-occlusive crisis in sickle cell anemia. Hemolytic anemia. Hemolytic anemia may be immune-mediated or non-immune-mediated mechanism. Immune-mediated hemolytic anemia either due to autoimmune mechanism or alloimmune mechanism or drug-induced mechanism. Non-immune-mediated hemolytic anemia either hereditary or acquired. Hereditary causes due to RBC's membrane defect as in hereditary spherocytosis or enzyme defect as G6PD deficiency or hemoglobinopathies as thalassemia and sickle cell anemia. Acquired non-immune mediated hemolytic anemia may be due to infection or BNH or mechanical as in DIC, hemolytic uremic syndrome, and TTP. Classification of immune hemolytic anemia. Immune hemolytic anemia caused by antibody-mediated destruction of RBCs. It may be due to autoimmune mechanism or alloimmune mechanism or drug-dependent mechanism. Autoimmune hemolytic anemia classified according to thermal amplitude of antibody into warm type, cold type, and Donat-Landsteiner type. In warm type of autoimmune hemolytic anemia, antibody reacts at 37 degrees and it is a common type. Cases of cold type of autoimmune hemolytic anemia, antibody reacts at 4 centigrade. In Donat-Landsteiner type, antibody reacts at both warm and cold. Alloimmune mechanism induced by red cell antigens, as in cases of hemolytic transfusion reaction or hemolytic disease of newborn or post-stem cell allograft. Drug-dependent mechanism may be due to antibody macrophage mediated or antibody complement mediated or membrane modification. The hallmark of immune-mediated hemolytic anemia is presence of immunoglobulin G, complement, or both. So, 95% of warm cases is positive antiglobulin test. Antiglobulin test is two types: direct antiglobulin test and indirect antiglobulin test. Direct antiglobulin test used to detect antibody attached to RBCs, while indirect type used to detect free antibody in the serum. Now we will talk briefly on some types of hemolytic anemia. Non-immune hereditary hemolytic anemia, which may be due to RBC's membrane defect. The common example for it is hereditary spherocytosis. Hereditary spherocytosis, due to defect in spectrin molecule, result in loss of RBC's membrane and formation of spherocytosis in peripheral blood and increased MCHC due to cellular dehydration. In hereditary spherocytosis, there is decreased deformability of cells and extravascular hemolysis in spleen and increased osmotic fragility test. What is the osmotic fragility test? Test used to measure the ability of RBCs to swell. RBCs suspended in increasing hypotonic saline solution of different concentration. Normal RBCs have flexible, distensible membrane, so can take high volume before hemolysis. While in cases of hereditary spherocytosis, these cells are osmotically fragile, where hemolysis starts earlier than normal cells. Hereditary non-immune hemolytic anemia also may be due to enzyme defect, as in cases of glucose 6-phosphate dehydrogenase deficiency. G6PD is a key enzyme in the hexose monophosphate shunt, which maintain healthy hemoglobin by protection from oxidant stress. G6PD deficiency is X-linked disease. Deficiency of G6PD leaves the individual susceptible to intravascular hemolysis during infection or on exposure to certain drugs or vaccines. To detect enzyme defect in cases of G6PD deficiency, direct assay of G6PD activity is required. This picture of blood film during an acute hemolytic episodes in case of G6PD deficiency, showing anemia, irregularly contracted cells, keratocytes or bite cells, and red cells with hemoglobin retracted into half of the RBC's membrane. Non-immune mediated hemolytic anemia either may be due to hemoglobinopathies, as in cases of thalassemia and sickle cell anemia. Thalassemia is genetic defect in hemoglobin synthesis, result in decreased synthesis of one of the two globin chains, either alpha or beta. Imbalance of globin chain synthesis leads to depression of hemoglobin production and precipitation of excess globin, which is toxic, resulting in ineffective erythropoiesis. Ranges in severity from asymptomatic cases to incompatible with life, as in cases of hydrops fetalis, found in people of Africa, Asian, and Mediterranean heritage. To detect defect in cases of thalassemia, hemoglobin electrophoresis is recommended. Normally, the two alpha globin genes are found on chromosome 16 and the beta gene are found on chromosome 11. Genetic types of thalassemia. There are two basic groups of thalassemia, alpha thalassemia and beta thalassemia. In alpha thalassemia, the alpha genes are deleted, either loss of one gene or both from each chromosome 16, in association with production of some or no alpha globin chain formation. In beta thalassemia, there is defective production, usually result from disabling point mutation causing either no production for beta chain or decreased production for beta chain. Classification of thalassemia. Thalassemia can be classified clinically into thalassemia major, thalassemia intermediate, and thalassemia minor. Thalassemia major, it is severe transfusion dependent anemia, while thalassemia intermediate, it is anemia not transfusion dependent. Hemoglobin electrophoresis in cases of beta thalassemia major show increase in hemoglobin F. Beta thalassemia minor or heterozygous status of beta thalassemia, there is one normal gene and other one abnormal gene. Hemoglobin electrophoresis show increase in hemoglobin A2 up to 7% in all cases. And CBC show special character by heterozygous beta thalassemia called thalassaemic indices. There is no or mild anemia. RBC's indices are decreased but not correlated with severity of anemia. There is high RBC's count and normal red cell distribution widths. Sickle cell anemia. Sickle cell anemia is chronic hemolytic anemia characterized by sickle-shaped RBCs caused by homozygous inheritance of hemoglobin S. Single base pair mutation result in single amino acid change. In hemoglobin S, valine is substituted for glutamic acid. Hemoglobin S is much less soluble than hemoglobin E, cause RBCs to sickle at sites of low BO2, forming long polymers. This leads to membrane changes or sickling and vasoocclusion. Hemolysis, because sickle RBCs are too fragile to withstand the mechanical trauma of circulation. Occlusion in microvascular circulation caused by distorted, inflexible RBCs adhering to vascular endothelium. Testing of sickle cell anemia include red cell sickling test and hemoglobin electrophoresis. This picture shows sickle cell mutation. Normal adult hemoglobin formed of hemoglobin E. Single point mutation of normal adult hemoglobin result in shift in nucleotide from adenine base to thymine base. This defect will result in shift in 6 amino acid from G to V and formation of GTG base instead of GAG base. This picture shows sickle cell mutation. Normal adult hemoglobin formed of hemoglobin E. Single point mutation of normal adult hemoglobin result in shift in nucleotide from adenine base to thymine base. This defect will result in shift in 6 amino acid from G to V and formation of GTG base instead of GAG base. Sickle cell disorders. Sickle cell disorders may be sickle cell anemia, in which it is a specific form of homozygous state of sickle cell disorders, in which hemoglobin present is hemoglobin SS, no evidence of hemoglobin E. While sickle cell trait is heterozygous state of sickle cell disorders, in which there is hemoglobin E and hemoglobin S. There are other variants of sickle cell disorders, as sickle hemoglobin C, in which electrophoresis show hemoglobin S and hemoglobin C, or sickle thalassemia disease, which is a combination of sickle cell trait and beta thalassemia trait. Non-immune hemolytic anemia also may be due to acquired causes, as in cases of paroxysmal nocturnal hemoglobinuria. BNH is acquired clonal cell disorders, result in deficiency of GBI-associated proteins CD55 and CD59. These proteins protect RBCs from continuous action of complement. Absence of these proteins result in failure to inactivate complement and increased cell lysis, ongoing intra and extravascular hemolysis. Classically occur at night. To detect defect in paroxysmal nocturnal hemoglobinuria, flow cytometry to detect CD59 and CD55, which is decreased or negative. Microangiopathic hemolytic anemia can cause non-immune acquired hemolytic anemia, as in cases of thrombotic thrombocytopenic purpura or TTP, and hemolytic uremic syndrome or HUS, and disseminated intravascular coagulopathy or DIC. Fragmented RBCs and thrombocytopenia in patients with thrombotic thrombocytopenic purpura. The size of the RBCs is approximately equal to size of the nucleus in non-reactive lymphocyte. This picture shows fragmented RBCs or schistocytes in blood film that help in diagnosis of microangiopathic hemolytic anemia. Mean lab findings of hemolytic anemia. The first one is features of anemia. There is decrease in hemoglobin, RBCs, and baked cell volume. Anemia is normocytic normochromic, except in cases of thalassemia, hemoglobin C and hemoglobin S, anemia is microcytic. White BCs and the platelet may be increased. Evidence of increased RBCs destruction as increased indirect bilirubin result in mild jaundice, increased fecal stercobilinogen and urinary bilinogen, increased LDH and decreased folic acid result in macrocytosis. Iron overload, increased serum iron profile and decreased TICB. Decreased serum haptoglobin and hemopexin, methemoglobinemia. Evidence of increased RBCs production as reticulocytosis and increased RBCs count result in blood film in picture called polychromesia and normoblastemia. Special test to detect the cause of hemolytic anemia. This picture shows the mean lab evidence in cases of hemolytic anemia. Lactic acid dehydrogenase or LDH, reticulocytic count, and bilirubin. LDH is a nucleic enzyme which is released on RBCs destruction. Concentration of it measurable from a blood sample and provides an indicator of hemolysis. Reticulocytic count will be elevated in response to feedback loop during anemia. Hemolysis results in excess bilirubin causing jaundice, lemon yellow color, and pigment gallstones. There are special tests that can be used to detect the cause of hemolytic anemia. Coombs antiglobulin test used in cases suspect immune hemolytic anemia. Osmotic fragility test in cases of hereditary spherocytosis. Red cell cycling test and hemoglobin S solubility test in cases of sickle cell anemia. Hemoglobin electrophoresis used to diagnose hemoglobinopathies and thalassemia. Red cell enzyme assay used in cases of RBCs enzyme defects. Autohemolysis can be used in G6PD deficiency, pyruvate kinase deficiency, or spherocytosis. Membrane protein analysis is used in membrane defects. Ham and sucrose lysis test and GPI-linked protein analysis by flow used in cases of PNH. Oxygen dissociation curve to detect high oxygen affinity of hemoglobin F. Morphological abnormalities in hemolytic anemias. Polychromesia, as in cases of reticulocytosis. Reticulocytes appear in Leishman-stained blood film as polychromatic cells. Target cells. Target cells are deeply stained area of hemoglobin surrounded by pallor followed by dark area. Target cells can be seen in cases of thalassemia or hemoglobin C disease. Sickle cells can be seen in cases of sickle cell anemia. RBCs with tapering ends. Schistocytes or fragmented RBCs as in cases of microangiopathic hemolytic anemia and thalassemia. Spherocytes are small, rounded RBCs, deeply stained and have no central pallor. Spherocyte can be seen in hereditary spherocytosis or autoimmune hemolytic anemia or APO hemolytic disease of newborn. Agglutination or clumping of RBCs as in cases of cold agglutinin disease. Heinz bodies detected by supravital stain and present in the periphery of the cells can be seen in cases of unstable hemoglobin and G6PD deficiency.